This clinical video demonstrates a case of TAR syndrome and its management. 15-day-old male child weighing 2.5 kg presented with complaint of abnormal hand since birth and vomiting since 5 days. There was no history of antenatal drug intake except iron and folic acid. There was no history of similar complaint in other siblings. Antenatal ultrasound was not done. On examination, both forearms were short, both hands are normally present with 4 fingers and thumb. Papular eruptions present on forehead, chest interspersed with few petechiae. So what should be done next? We ordered X-ray both arm and forearm and complete blood count in view of petechiae. Complete blood count report showed thrombocytopenia with platelet count of 42,000 per microliter. X-ray of this baby showed bilateral absent radii. Other skeletal anomaly could not be identified. So the diagnosis is TAR syndrome. Let's review few more important points. Cow's milk allergy and gastroenteritis are commonly seen in these babies, as also in our case. Platelet counts in neonates are usually less than 50,000 per microliter, and thrombocytopenia is maximum at the time of birth. As age of baby advances, thrombocytopenia becomes less severe and most affected individuals will not require platelet transfusions after infancy. It should be noted that platelet size and morphology both are normal. Thrombopoietin levels are elevated in this syndrome. Bone marrow aspirate shows decreased megakaryocytes, although this finding is not necessary for making diagnosis. Coming to genetics, TAR syndrome has an autosomal recessive inheritance. A very important point which I forgot to tell you, that in both hands, thumb always present. Coming to differential diagnosis, TAR syndrome patients are phenotypically similar to Fanconi anemia patients, but absence of thrombocytopenia in neonatal patients, presence of progressive bone marrow failure, and only 30% patients with radial defect separates Fanconi anemia from TAR syndrome. A megakaryocytic thrombocytopenia with radioulnar synostosis is differentiated from TAR syndrome by its autosomal dominant pattern of inheritance, persistence of severe thrombocytopenia, and progression to aplastic anemia. As far as trisomy 18 is concerned, presence of esophageal atresia distinguish this condition from TAR syndrome. It should be noted that there is no definitive treatment available, so treatment is symptomatic and supportive. As these babies are allergic to cow's milk, so mothers are advised to exclusive breastfeed their babies for at least 6 months. For thrombocytopenia, single donor irradiated platelets preferred to maintain counts above 10,000 per microliter and may be needed with higher counts, as in our case, if signs of bleeding are evident like petechiae. For limb anomaly, orthopedic consultation is advised.